All right, good morning, everybody. Again, welcome to Saturday morning CASA Congress 2018. I hope you all enjoyed yesterday's lectures, and for those who managed to make it through the AGM last night, well, the lucky ones, we handed out 2 Virgin Active memberships, one being the premium. And so when you stick around for everything, luck might just follow you. So let's keep your attention going. I don't know if anybody would like to win Nedbank Sun City hospitality tickets today. So we are going to have one of our esteemed staff members from Nedbank. He's from Merchant Services. He's a regional sales manager for Gauteng, and we have had some extensive talks with him. We feel that the biggest return on investment for both parties will lie with Merchant Services. And if we get a good rate, and they get enough of you guys to buy into it and use merchant speed points with Nedbank, the better, the better rates we can get. If we just have one with this bank and one with that bank, and then we can achieve nothing. Okay, so the idea is for you in your practice to make some decent money, and the point of sale is because we're a cash business. We had some very good boardroom meetings here. They are prepared to meet us, and they are making a big effort. And once again, Nedbank, really, you guys are impressing me. So thank you. Ladies and gentlemen, can you please welcome Mr. Mark Naidu?
Morning, everyone. Thanks for having me on a Saturday morning. I know banking is not the most exciting topic early in the morning. And thanks, Mike, for the introduction. I think you've taken care of half my presentation, but okay. But we'll get started. Merchant services and payments in particular play a vital part in our everyday lives, and especially as business owners, the customer experience. I mean, you guys work so hard in giving the best service, and the payment leg of it should be seamless and easy as well. And the way technology is moving these days, we've got various options. I mean, we've seen a switch over the years from cash to card, and now we're looking at a migration from card to e-commerce and e-wallet as well. So the payment space is always evolving and changing, and today I'm just going to take you through a couple of the solutions that are applicable to your space. Okay, if you guys have any questions, please stop me at any time, okay, and we can address them. Okay, so I'm sure all of you know the conventional means of payment, which is the card machines. At Nedbank, we've got 3 options. We've got our fixed unit, which is what you'll typically find in the retail space. This unit requires a power supply. But what's different with our machine, it's got a variety of communication methods. So no matter how good your card machine is or how up-to-date it is, the communication is actually key to get that transaction through. With the fixed unit, you can either connect via SIM cards, and we have dual SIMs, so Vodacom and MTN. So if one network's down, you can automatically switch over to the next one. Our machines can connect via modem or your internet line as well, your ADSL or your fiber, okay, which not many banks can do. So that's our fixed unit. Our portable unit is for typically you'd find in the restaurant or the forecourt space. So this machine's fully portable, also uses dual SIMs, and it'll function as long as there's cell phone signal. Our uptime, I think we've got industry-leading uptime. When I last month was 99.7%, which is way ahead of our competitors. So in terms of our system stability and the reliability on terminals, we're right up there. Okay, and the last one is our POS Plus device, which is soon to be relaunched. I'm sure you've seen the adverts for Pocket POS and so forth. We've taken it one step further. So this is the device for merchants on the go. It pairs with your cell phone, and you can accept payments anywhere, anytime. What's different with the new version of it is that we've now built on an inventory system and an online page. So for 400 a month, you get the card reader, plus you get an online web page, and you get a stock management system. So it may not be applicable in your space in terms of treatments, but if you guys stock various value-added products that you sell, I mean, that's a great product to actually, expand your reach or reach more people via an online page. Okay, so that's our conventional card machines, and I spoke about the migration from cash to card and card to e-commerce, and our e-commerce solutions are also right up there. I mean, most of the major retailers that you find online all use NetBank products, and so our system technologically right up there, stability right up there, and we've got three options. Our enterprise option would be for the Takealots and the Superbless and the Zandos of this world. So if you want to control your online payment page from end to end, that's the product that you would need. I think the other two, NetBank Lite and Divert, would be more applicable in your space. So if you want an online presence, NetBank Lite takes the technicality and the complexity out of it for you. All you have to do is set up your web page and we'll handle the payment part of it. So if you want to sell braces or whatever items that you want to punt online, your patients can click on your web page, they can choose the product that they want, and when they want to pay, they'll get directed to a NetBank page, thanks Mike, where they can complete the payment. The key element with online trading is the safety of the card details. You know, when you punching in your card details on a website, who's storing that information? Can it be used elsewhere? You know, can it be duplicated? And we've seen, unfortunately, a spike in online card fraud. So I think things to look out for, just make sure that those websites that you use are secure, and always have a look at when you're punching in your card details, whose site it's on. So from a NetBank perspective, we've taken that part away from you, and with the NetBank Lite product, we host the payment leg of that transaction, which is great. The third item which is NetBank Divert, we've seen a lot of success in the medical industry. And the common challenge that we found is that you guys sometimes struggle, well, not the chiropractors per se, but the medical industry struggle to collect payments from patients from time to time. And you've got someone that's sending out, posting invoices, making phone calls to follow up on payments. So with NetBank Divert, we give you an online platform where you can attach the invoice, attach a time frame to it to say that this is valid for 10 days, and it gets emailed to the patient with a payment page. So all the patient needs to do is open up the invoice, put in their card details, authenticate the transaction, and you'll get a notification back to say payments made. And so especially if you're going to offer a discount if payment is received within 2 weeks or whatever the case is, you can customize it the way you want it to be. Okay. So very popular in the medical space. What's also popular is our new product called Gap Access. So this is not so much a solution, but more a tool to help you. So if you've got a card machine with NetBank, we can offer you or advance your turnover, give you your money upfront. So if we look at your turnover over a 12-month period, and if you need access to funds for equipment or, well, we're coming up to December now, we find a lot of our customers want to buy additional stock or do more marketing. Instead of going for a conventional business loan, you can use the turnover on your card machine to actually finance it. So we give you the money up front. It's not interest-based. There's a once-off 15% finance charge. And it actually assists with cash flow because there's no monthly lump sum that you have to pay. We take the repayment daily. And the term's quite short. It's either 6, 9, or 12 months. Okay. So instead of budgeting for a 10,000 Rand loan repayment, we'll take between 5 and 20% daily of your turnover, so you don't even feel it. Okay, so it's proved to be quite popular. Doesn't impact your cash flow, like I said, and it's the applications process fairly straightforward as well. Okay, this is one of our new digital products, and I'm sure you've heard of it. It's called Masterpass, and this is actually the way payments are going in future. I mean, we attend a lot of meetings in the payment space, and we're questioning the model. Why does it have to be so complicated when making a payment? You've got a bank, and then you've got a cardholder, and then you've got the cardholder's bank, and then you've got BankServe, and all of these parties are in there taking a slice of the pie, so to say, and it makes the transaction more successful, or more expensive, rather. And we're re-looking at that now. Why does it have to go that route? Why can't it just be person to person or business to business? Masterpass is one of those products that are going to give you the platform to do that. Okay, so it's fairly new. At the moment, the functionalities are limited to scanning QR codes, but looking into the future, we find that it's a lot more possibilities when it comes to this product. So very, very simple. You download the MasterPass application from any app store. You enroll your card. So you load your card details on. It encrypts those card details. And whenever you see a QR code or a merchant that accepts MasterPass, all you do is you scan the code with your phone, enter your PIN number, and the payment's done. Okay. So it's very cool, it's very easy to use. You would find in the Nedbank canteens, there's codes at every payment point. So if you guys can, just download the app and try and use it. Easy to use. Okay, and then if we come to the package that we put together, and I know you guys are busy, you work your fingers to the bone, so to say. So we put together an awesome package to try and save you some money. So if you bank with Nedbank, our credit rate's 1.95%, our debit rate's 0.87%, and foreign's 2.45%. So we had a look at the stats, and if we look at chiropractors specifically, we find between 60 to 70% of the spend are debit card transactions, while about 30% would be credit card transactions, and a very small percentage would be foreign. Okay, so we looked at the debit transaction fee. 0.87% is quite low. I think it's lower than the industry norm for the industry, for chiropractors specifically. And even the rental. For the fixed unit that we spoke about, 270 Rand a month. I think the average is about 350 now. And the portable machine, 335 Rand a month. Average rental now with the competition is about 400 Rand a month. So fantastic rates on the commission and the rental. If you're not a Nedbank, a main bank client, also competitive rates, but slightly higher, 2.15 on credit, 1.05 on debit, and 2.7 on foreign. So a real incentive for you to bank with Nedbank. We've got some exciting products. And just to give you an insight into our product roadmap or what's happening in card over the next couple of months, we'll be launching a merchant portal very soon. So if you're a Nedbank merchant, you can log on and view your transactions, you can pull your statements, you can do your reconciliation, you can make requests, all via a live online platform. So that's one. Second one is we're introducing a loyalty program that will work off our card machines. So if you want to introduce something at your practice, your clients can simply enter their cell phone number into the card machine. We record the information on the back end, and we can customize it. If the customer visits you 5 times, on the 6th time they get a discount on their treatment, something like that. So you can decide how you can work it out, but that's coming as well. Okay. Any questions so far? Yes?
I think you forgot to mention that it's only for CASA members.
Absolutely. I mean, yeah, it's...
Non-registered CASA members.
I mean, that's why I'm here on a Saturday morning, just for CASA members. It's just for you. No, but on a serious note, guys, it's ring fence only for you guys. Any other medical professional, normal standard rates would apply. But for CASA members, across the board, I mean, you qualify for these rates. Okay, there was a question. Yes?
We need a mic there, please. Okay? Yeah, but it's for the webcast.
Hi. Sorry, I just wanted to ask you, if you're currently a Nedbank client,
Yes.
are these rates, are they going to change for us? Do we have to approach you with regards to that?
Well, we don't have sight on new members joining, but if you are a CASA member, you simply contact your banker, and those rates will apply, absolutely.
Okay, but what I'm saying is I'm already a Nedbank client, and
Okay.
I'm not paying those rates, if that makes sense.
No, I understand. Well, then you should be paying those rates, because
Okay.
if you're a CASA member, so please get in touch with your banker so we can have a look at that and amend it.
Okay, thank
Okay,
you.
Thank you. Okay, any more questions, guys? All right. All right, so thank you for your time and enjoy your conference, and all the best. Thanks.
All right. That was a lot of negotiation to get that, and thank you very much, Nedbank. And guys, please make sure that you support that initiative, because we appreciate everything that they've done for us. This morning, we got a great lineup, a good emphasis on radiology and the diagnostics around it. So, without any further ado, we're going to, our first speaker for the morning is Dr. Margaret Seren.
There we go. So I thought I might start out this morning with taking, how about if I say 2 questions, because I wasn't able to take your questions yesterday, and then obviously I will take more questions. So does anyone have a list? There are no questions. Is anyone, all right, do we have a mic? Oh, you're saying no now? Anybody? Very good. Here we go. Can we have a mic here?
Good morning. Very quickly, relative to the slide that you showed on the vascularization of the disc yesterday,
Yes.
has there been any clinical radiological evidence post-operative, once that disc has now been removed and they put an artificial disc in, that vascular supply, what happens to it, and does the osseous structures of the end plates around that new artificial process that's been put in, is there any evidence to show that that osseous tissue degenerates because of the vascularization being upset?
That's a great question. I don't know of any studies that have addressed that. Most of the studies following disc prostheses have looked into symptoms, adjacent segment degeneration, but when they put in a prosthetic disc, they generally, besides removing the disc, in order to facilitate the prosthetic disc to be anchored to the vertebral bodies, they generally speaking rake the surface of the end plate. I've seen it done a couple of times, lumbar spine, and it's a little bit shocking, but they do that and so that the bone will grow down into some crevices of the prosthesis. So there's no doubt that the vascularity changes. I'm sure there's incredible neovascularity because of the injury to the end plate. As far as the decrease in pain, it would be we no longer have a disc that's breaking down, that's releasing the cytokines and whatnot. And so I think that plays a role. And so you wouldn't have that continue as far as being a cause of pain. But there hasn't been, really good studies regarding that. Anybody else? All right, good. Well, then we'll just get started, and I promise I will take questions as we go along. Hopefully I'll address some of them, but I have no problem taking questions because I feel like if you have a question, probably half the room has the same question, and so it's important to address it. So I'd be happy to. So yesterday we talked about the magic of MRI, and I'll remind you that on T1, the first time we listen to that signal, water is black, and on T2, water is white. And we need to look at both of those because we're looking for water where it should be and where it is and it shouldn't be. So that's what we're attempting to do. We all like to look at the T2 because the CSF is white, and so the structures stand out a little bit more. But don't be tempted to only look at those, look at both. So the reason why MRI is so fantastic to show the early degenerative changes is that it shows the dehydration that occurs as our first process in degenerative disc disease. And you can see in this person who is actually 42 years old, if you look up at L1, 2, 2, 3, 3, 4, it looks pretty good. We have still a nuclear area, but do notice that you have that horizontal line that is beginning to pass through. That's the earliest signs of degenerative change. And why it occurs in that horizontal pattern, nobody really knows. But then when we get down to L4, 5, you can see there's very little signal left in the region of the nucleus pulposus. And now we're down at 5-1, and we see little to no. So that I would read that as mild to moderate disc desiccation at L3, 4, 4, 5, and then pretty significant advanced desiccation at 5-1. So yesterday, John discussed the Fardin and Millet studies, and you can see in 2014, his second author was Williams. And once again, please do go on there and download those, because you can grab some of the images off it. And I think visually it's good to understand when we have that. But before I go through each of these things, they're very important, I want to talk about something that is in the article, but we haven't. Everybody focuses on the disc herniation, which is an important finding. But before a disc herniates, it undergoes a process that we refer to as internal disc derangement. That starts with the dehydration I just showed you, but then as the disc dehydrates more and more, it develops these fissures, what I'm still tempted to call tears, but I'm trying to be current. And you can see that those are potential spaces. When they become large enough, then gas comes out of solution, and that's what we see as our vacuum phenomenon on plain film X-rays. We cannot see vacuum phenomenon on MRI, but we can see the annular fissures. And this excellent diagram from ChiroGeek shows a number of different types of fissures that we see. Now, this type, which he refers to as a concentric tear, that's actually a delamination process. Remember, the annular fibers are oriented in all different directions, some vertically, some horizontally, some cross fibers, in order to give strength to that annulus. So that's referred to as a concentric delamination, because that makes the most sense to me. Some people might say tear. The radial fissures are the ones that are associated with disc herniations. Disc herniations in the adult are a many years process. Now, that's not true in young teenagers. I have a number of cases over the years where one of them was a 13-year-old female, and she was a distance runner in high school, and she was encouraged by her coach to strengthen her legs, and so he had her doing presses with her legs. This tiny little thing, she was 90 pounds, she was pressing 300 pounds. Acute, enormous disc herniation. Now there, it is a tear. That's not a fissure that's developed over time. But in we adults over the age of about 25, probably, we it's a process that's occurred. Now, there's another lesion, so to speak, that's referred to as the rim lesion. And we see these readily on X-ray all the time. And it is actually a separation of the annular fibers from the end plate. The Sharpie fibers fail with time, they dry out, and with flexion and extension, it separates, and I will show you some of those. So that just gives you an overview of some of the things that we can see. And here's one of those rim lesions. You got to look for them, they're subtle, but you know by seeing that on your plain film x-rays that your patient is undergoing internal disc derangement. Can that be a cause of pain? Yes, if there is enough breakdown of the disc that inflammatory markers are irritating those nerves that have accompanied the blood vessels that go into the periphery of the disc. And here, just a cadaver specimen of what these look like. We see them when they're filled with gas, as here. And one more thing I want to point out to you. There's that retrolisthesis that I want all of you to start looking for. You see retrolisthesis at a motion segment, you know that's not a normal disc. And on this patient who's actually got, will you tell me whether that's a protrusion or an extrusion? A little bit hard. I'm not giving you all of the images. I'm not giving you the sagittal. But yeah, I would like to call this probably a protrusion. Now, where we would be wrong is if on the sagittal image we saw that there was migration above or below the level of the disc. Remember? So, but with just this one alone, I would be inclined to call that a protrusion. But here's what I want to point out to you. All of the changes within that disc, instead of there being a central area of nucleus pulposus, there's a shift of bright signal posteriorly, and then here and even here within the herniation. Those are regions of inflammation. And those are where you get irritation, even radicular symptoms, because of that sinovertebral nerve being irritated. And these are, I think, beautiful images from a cadaver, and I showed you this one yesterday. It's pink because of all of the infiltration of the neovascularity. And then you can see how as that occurs and the disc fissures, it's a perfect highway through which disc material can herniate. And I want you to all to realize that disc herniations can be nucleus pulposus, annular material, pieces of the cartilaginous end plate, as well as pieces, tiny little fragments of bone. So another term that we all have to stop using is herniated nucleus pulposus. That is a misnomer. Perhaps in that 13-year-old, that's what her herniation was, because she actually did have a tear, and the watery nucleus herniated. But in an adult, it is a disc herniation, and we have to lose that nucleus pulposus terminology. And a lot of the pain, I would say 95% or more of the pain, is due to the inflammation. It is a chemical-mediated pain that we are feeling when we are undergoing both disc degeneration and herniation. So when we see a disc herniation, we would like to describe it in terms of its location. And this nicely shows here at the L4-5 disc, you can have a posterior central disc herniation. You could have a lateral recess herniation. And then you always have to look out. Remember, these things can go anywhere or occur anywhere. You have to look out in the zone of the IVF. So your MRI reports, you'd like to know, is it a protrusion or an extrusion? You'd like to hear the words contained or not contained. You'd like to know its exact location. And the other thing you'd like to know is its consequences, any deformation of the thecal sac. So you'd like to know whether the thecal sac is displaced posteriorly, to the left, to the right. And that will help you determine whether or not that herniation is playing a role in that patient's symptoms. Remember, patients can have herniations at multiple levels. And part of we chiropractors are very good at saying, rule out disc herniation at L4-5, because we're great with figuring out dermatomes, and its radicular pathway. So, but you would like to know, because patients don't often have, unless they're young, a single level of internal disc derangement or even herniation. So you'd like to know which one, in fact, is playing a role in their symptoms. And this is another way of thinking of the pain that's produced from our internal disc derangement and fissures. So this illustrates here a posterior central radial tear that now is inflaming the sinovertebral nerve. This one is posterior and eccentric to the left. So they're more likely to have left-sided pain and even radicular symptoms. I want to remind you that the inflammation alone can cause radicular symptoms. We no longer accept that it is the herniation that is pressing on the exiting nerve root that's causing the pain. It's an inflammatory process that then is irritating that exiting nerve root. And that's what we call this chemical radiculitis. Some people believe that just the inflammation here, even in the absence of protrusion, is like a space-occupying lesion. It's an inflammatory tissue that is putting pressure on the annular fibers and the PLL. So this internal disc derangement is from the breakdown of the disc. And then one more thing that I'm going to address in more detail, because I want you to understand its role in symptoms and what you are reading in your reports. And I want all of you to not just rely on the radiology report. MRI is nothing but anatomy and physiology. You all understand that. I want you to look at these MRIs and reach your own conclusions. Just like you were taught that with plain film radiology. Sure, you might be getting a report from someone else because they took the images, but you should look at those images and you arrive at your own radiological impression. So something else that we see in internal disc derangement and the degenerative process in a disc are end plate changes on an MRI. And initially, we thought that maybe it was an infectious process, and a lot of people had needles stuck into them and material extracted to see if they could, in fact, culture out bacteria. Well, it turns out that there is often in some people so much inflammation in the adjacent end plate, but that we actually see that on MRI. And Dr. Modic is the one who first described that after doing years and years of studies on MRI. And I will go into that. But you would like to know if there are, in fact, Modic changes and the type. There are 3 types, and I will go into that. So how many of you have seen reports of Modic changes on your MRI studies? Good. And it is something that's important. You want to know all of these things about your patient. So I wanted to put side by side a normal disc and then a disc that's undergoing internal disc derangement. So here's what a normal young nucleus pulposus looks like. Nice big central canal. This is the CSF within the thecal sac, and because the patient is recumbent, the nerve roots then settle posteriorly and usually form a little bit of a crest. So this one, first of all, what position is the patient in? Were they recumbent? They were standing. So this is one of the studies from one of the centers that I'm affiliated with, the stand-up MRI. So they're not standing, they're seated because we don't want them to move. But notice that the nerve roots are along the back of the vertebral body. If they were recumbent, if they were supine, which is the way we usually do it, they would settle out like we see here. But the other thing I want you to notice are the changes within the disc. Overall, it's desiccated, but then there are several little pockets of inflammation, water where it shouldn't be, in the annular fibers. And so even in the absence of a disc herniation, a protrusion or extrusion, that can be the cause of this patient's pain. And here's a nice example of a 20-year-old female with chronic low back pain. She has beautiful discs above, but here at L4-5, she has internal disc derangement. The disc is desiccated. There are little pockets of inflammation. Those are within the fissures that have formed. And she does have a very small protrusion. But her pain is probably not from that protrusion. It's from the inflammation within the disc. And in fact, studies have shown, John's going to go into this in more detail, patients with protrusions rather than extrusions often have a prolonged period of symptoms compared to patients with extrusions. The disc pathology is contained. The body has less ability to go in there with phagocytes and clean it up. And we'll show you some amazing cases and case studies from over the years. Here's another patient with internal disc derangement now at the L5-S1 level. And I would say that this patient has circumferential disc bulging, and I can say that with some certainty because I can see it anteriorly as well as posteriorly on the axial and sagittal views. But then besides the circumferential disc bulging and the internal disc derangement and the radial tear here, they also have a protrusion. And you can see the pathway that it likely took. There was a fissure there, and now this is inflammation. What else is in there? Probably some nuclear material, some annular fragments, But mostly what we see on the MRI is the inflammation. And once again, a patient like this is often going to have a prolonged number of weeks, months, before the body can deal with this. Do they need surgery? Not in my opinion. But sometimes we have patients who end up going on to surgery because they are having difficulty dealing with the pain. Their activities of daily living are so impacted that they need to go on to it. But there is absolutely no impact on the thecal sac or the exiting nerve roots. Yes, question?
Would that intradiscal inflammation respond to anti-inflammatories?
That's a great question. One of the ways that the medical field in the US now is dealing with the protracted pain from disc herniations is by putting on Decadron patches. And a lot of times you can kind of break that cycle, and then the patient is able to become more active. The problem is with that pain is then we don't move. And if we don't move, our body can even less deal with the inflammation and carry it away. So I would say yes. As a chiropractor, what I would recommend first are some proteolytic enzymes. Now, whether they're going to have a great impact, it's hard to know, but bromelain, chymopapane, pineapple, and so on, and papaya, do that. I strongly recommend that. I would also, I'm not a treating chiropractor, but if it were me, I would go on a completely low inflammatory diet. I'd probably get rid of all gluten, sugar, just go fruits and vegetables, a little bit of clean protein, and try all of those things first. Be as active as possible. So that is a good question. Some patients, it still just doesn't work for them, and they end up going to surgery.
Another
Thank
question,
you.
please.
Yeah.
Another question, please.
Yes. Oh, right.
Yeah.
Oh, Dr. Till, of course.
What else? The fact of inflammatory process in acute disc protrusion or herniation is well established and not
Yes.
disputed. And you assess that in your opinion, 95% of the pain is from that inflammatory process rather than from any mechanical pressure of the herniated disc. Now, in my experience with these sort of cases, and I never send them for MRIs, I seldom, if ever, send them even for plain films, because my experience is that with conservative care and avoiding rotational adjustments, they will recover within 3 to 4 weeks on average. Now, if I lie the patient down in an acute stage, prone, perhaps a pillow to support the abdomen, and if I apply a distractive force manually, with one hand over the sacrum, other hand over upper lumbar spine, assuming we've got, say, an L4-5 disc, and you distract that, it gives them immediate relief as long as you hold that pressure. Now, that pressure, in my opinion, doesn't make any difference to the inflammatory process, but it could have a mechanical effect of reducing pressure in that particular area.
Mm-hmm.
And that is, in my experience, limited as it might be, is invariable. There might have been 1 or 2 cases where it doesn't make any difference. So that to me means that the mechanical component is more than just 5 or 10% in terms of pain production. So just something to bear in mind there. Then the other question that I have is insofar as the nitrogen, if I remember correctly, it's nitrogen gas that
Nitrogen gas,
is
yes.
produced in the degenerating disc in the early phases there. Now, when we adjust or manipulate a diarthrodial joint, it's an encapsulated joint, okay? So it's a closed space. We distract the 2 bones that are constituting the joint, and therefore we increase the volume and therefore decrease the pressure within the joint, and that sucks the carbon dioxide out of solution and contributes, we think, to the popping sound.
That's what we think.
Yes, yes. What do we think causes the production of nitrogen gas in the degenerating disc?
What do I think? I mean, I don't know that it's. John, have you ever read what exactly? It's just that it's a space. It's a space, and we don't like to have empty spaces in our body. And I think, I don't really know the answer to that. But if it were empty, it would be a vacuum. And we just don't have vacuums in the body. And I guess if there's not enough fluid left in the adjacent disc to move into that space, then it's nitrogen gas that comes out of it, but I don't know. I don't know the answer to that.
So quickly, I do happen to have a relatively recent article that addresses this in a roundabout way. The title is Excessive Reactive Oxygen Species Are Therapeutic Targets for Intervertebral Disc Degeneration. A number of Japanese authors. They are looking at the effect of oxidative stress on the disc. And so their methods were to measure a marker of oxidative stress, nitrotyrosine. Was assessed by immunohistochemistry and Western blotting. So obviously, I guess the point here is that there are a number of chemicals that are created or that develop in the presence of this breakdown process of the disc, some of which seem to have a nitrogenous component. So I'm guessing that this is just an effect of the breakdown, and that's how it ends up being a nitrogen gas accumulation.
Thank you. That's very interesting. And you mentioned oxidative stress. Now, it's well established in the literature that near-infrared light is most useful in the management of oxidative stress, regardless of which tissue is involved. And it would be interesting to see if anyone is able to pursue this in terms of early degenerative changes, perhaps animal studies or something of that nature initially, to see if the use of near-infrared light can help retard that degenerative process.
Thank you. Good discussion.
Sorry, Doc?
So I just want to show you. Oh, another one. Okay, sorry.
I just want to firstly thank you for showing me that I've been speaking a bunch of mumbo jumbo to my patients for 18 years. When they're presented with neurological symptoms and they're not getting comfortable, all the tests show there's nerve irritation. What I've sometimes done is send them for a cortisone infiltration, and with the belief that if they feel better within a few hours, it was an inflammatory reaction. And if they felt no different, I'll say, oh, sorry, your nerve's being compressed. So are you saying now that it's not the compression, so therefore the inflammation was too severe and one infiltration wasn't enough? Maybe give them another one in a week's time?
Well, they still do cortisone injections. And cortisone injections now are going to bathe the area around the thecal sac and help to decrease the inflammation of the nerve roots. The problem with the cortisone injections is that if the inflammation is inside the disc and in the end plates, it's going to have a lesser effect on their symptoms.
If it's an extrusion, the chances that they'll feel better was more likely.
If it's an extrusion, it may well be a good thing. Here's the reason why cortisone injections are not optimal. Sometimes our patients have to have it, or one of us, we just can't function. But the problem with cortisone is that it decreases vascularity. Part of the way that it decreases pain is it decreases vascularity, blood flow. And when we have a herniation, we want a lot of blood flow in there. The inflammatory process is what is going to phagocytize, bring in that to clean away the disc herniation. What's that? I'm going to get into that. Yes, and John's going to discuss all of that. So, we have these tools, but we want to, with as little intervention as possible, support the body to do what it knows to do to handle this process. But sometimes people just can't make it without it. So I have this one patient that I want to show you multiple levels of disc pathology. And you can see this is the L4-5. So if we look at the sagittal MRI, it's parasagittal, it's not midline sagittal. You can see how desiccated it is, but once again, it's important to look at your axials because you can see this large radial fissure and all of the inflammation within it. And I think I have another one here at the same patient now at L3-4. You can see there still is some good hydration of the nucleus pulposus. They have a bulging, but only seen on this axial, they have an eccentric to the right radial tear, and that is why this particular patient has right leg symptoms. Not only back pain, but they have right leg symptoms. And these are the kinds of things that you would like to know from your MRI report. Yes?
Sorry, I'd just like to ask, why are you swapping for us if we're looking at it left and right?
Because the patient is recumbent,
Head toward us.
The right is always on our left. Always. Always.
That's also never reported here. Opposite way.
It's always like that. Even when we do them seated, the right side is always on the left. And often, now I have cropped these, but if I had shown you that whole thing, you would see an R there. And even if it isn't, it's always the right side. Yeah. All right, good. That's a good question. So, another term that I want you to be familiar with is the high intensity zone, or HIZ. So, what is it? Well, you can look and you can see what it is. It's this. It's an area of increased signal within the disc. Often there's a herniation associated with it. Not always, though. It's along the periphery of the disc for the most part when it's that little nidus of inflammation. What does it mean? It means there is fluid there, water, and it is likely the response to the breakdown of the disc or the fissuring. And here's where I want to go back to that tear. And, it's more of an acute process. Our bodies are not going to keep that. We're going to clean it up. So what this means, in my opinion, and most radiologists now, is that it is a region of acute inflammation. Is it the symptomatic disc? Most likely. However, patients can have 2 or 3 symptomatic discs. And when there's a herniation associated with it, is it an acute herniation. You know, because some people have chronic herniations. They're not inflamed anymore, they're not symptomatic anymore, but our body can't suck all the disc material back into the confines. But when you see a high intensity zone, you can be fairly certain that that is an acute process. If there's a herniation, it is an acute disc herniation, and it often will correlate with the patient's symptoms. So do look for that. And there we can see it on the axial image as well. That is not going to stay. So you can see that this patient has, we're going to call that a protrusion, right? Well, there's a little, this is where it starts to get iffy. There's a little bit of superior migration, isn't there? So then I would be wrong to call that a protrusion. So I'm going to call that a extrusion that has migrated up along the posterior aspect. We're going to call this L5S1, so posterior aspect of L5. And there is some mild flattening of the anterior portion of the thecal sac. And you can see that this patient was recumbent. And actually, this was my, well, it still is my brother, but it was from, it was from quite a few years ago. My brother's an orthopedic surgeon. Some pretty good dinner table conversations. He's 10 years younger than I, so he's almost like my son. And I went into chiropractic school before he was even out of high school. And so he wanted to go to medical school, which is completely fine. And when he told me, well, and actually at one point when I was young and in high school, that's what I wanted to do too. But then I learned about chiropractic. And so anyway, he told me he wanted to be an orthopedic surgeon because all of his buddies were becoming orthopedic surgeons. And I just said, you know, Vince, don't operate on the spine or I'll have to kill you. And so he doesn't. He's at the University of Connecticut, and he works at the medical school and trains fellows and residents and all. And he does extremities, primarily lower extremity and hips, and he's very good. And he gets chiropractic care. He's my first family member that I sent for chiropractic. But anyway, I have to tell you this because he knows how I feel about these things. So he was doing a fellowship, and he woke up one morning, and he had, his main symptom was foot drop. He'd had chronic low back pain, you know, all through high school and medical school and everything. So he wakes up and he's got foot drop. So he goes into the hospital and, oh my God, and they do this MRI, and I'm sorry, that's pretty darn puny herniation. But what did he and all of his buddies decide? He's got to have surgery right away. So at 9:30 that night, after his buddies had been doing surgery all day long on their patients, now, he doesn't even let them sleep and then go in at 5 in the morning. He has a discectomy. And you know what? He had foot drop for the next 12 weeks. Slowly, it came back. And I pose to you that without the surgery, that foot drop would have improved as the inflammation went down. But I was a pretty good sister and walked with him as he was rehabilitating himself. And I'm sad to say he's gone on to have cervical spine surgery. So you can only do what you can do. So look, Dr. Till.
Forgive me.
I'll try.
When, in your opinion, does that migrated disc that you showed us in the previous image, when do you categorize it as a sequestrated disc?
When it's separated, and I will get to that. When there's a separate piece, and yeah.
So forgive my
If it's still attached.
I still can't see the attachment on there, so my apologies.
Well, so this is inflammation within the herniation. So the herniation is all of this, and it is still contiguous with the parent disc. So that's why I call that migration. And if there were, in fact, another piece up here, then that piece would be the free fragment or sequestration. Yeah, good.
Sorry, just one more. Linked to your brother's issue.
Yes. He's got a lot of them.
I don't even know him, so sorry. You know, if you look at sort of talking about if he didn't have the surgery, potentially in 12 weeks' time it might have come right on its own. When do you actually start being concerned about permanent neurological injury?
Mm-hmm.
You know, how long do you leave it? When do you panic? You know, it all seems to be up in the air.
It is, and it still is up in the air. So what I always tell my clients is monitor for progressive neurologic loss. So if in fact then he started to develop muscle atrophy, you know, or just monitor them. And at that point, I'm not saying they definitely still need surgery, but we need to then co-manage this with a neurosurgeon. Or, you know, if I were going to have a disc surgery, if I had to have it, I'd go to a neurosurgeon. Sorry, my brother Vince. But I don't know. So, and I can't tell you so many weeks. I really can't tell you that. John's going to talk a little bit about, they've done some studies on foot drop and neurologic deficit. Thank you for your questions. They're, you know, it's good that we address these.
Something that hasn't been brought up, you may bring it up in the future, is myelopathy. I think that's where we need to be very aware, because that can be a highly dangerous thing.
Tomorrow I'm going to talk about stenosis, and I will address myelopathy.
Great,
Yeah.
thanks.
Yeah. All right. I got to keep moving. So.
To your left. Left down. There we go.
Sorry, this side of the room is getting short shrift.
Can you go back a slide?
Yes, you bet. One more?
One more. Yeah. I just want to ask that area of low intensity signal through the disc, is that a chemical sort of artifact that we see on the sagittals?
These lines?
Yeah. Is that artifactual?
Some of it is, but some of it is early degenerative change. So, because we do see it in young people, and it is like the artifact that we see in the canal sometimes. So it's both. It's both. All right, I got to keep moving. I want you to be aware of high-intensity zones in locations that we're not inclined to look, perhaps. And so here you can see there's a high-intensity zone. This is at the level of the IVF, so we're quite a bit parasagittal. And here's another one. And it helps to explain this patient with persistent back pain and leg pain. So you want your radiologist to be reporting all of this to you. So the next thing that I want to bring up is this whole contained versus uncontained. And this is where it is correlated with clinical response. So the first thing that we need to remember is that the posterior longitudinal ligament at the level of the disc is really not a separate structure anymore. It is contiguous with those outer annular fibers. Whereas along the back of the vertebral body, you could take a probe and you could put it between the vertebral body and the PLL. But then if you were to pull it down to the level of the disc, it's not separate. It is contiguous. So when we're talking about whether a disc is contained or not contained, we are talking about whether or not it has gone through the outermost layers of the annulus and the posterior longitudinal ligament. And unfortunately, on MRI, I don't have all those different colors and things are not labeled. But what can tell you about whether it is contained or non-contained is the configuration of it. And sometimes you can actually see that interruption of it. So I just want to remind you of that anatomy. So here's what I want someday to have it be in color. The PLL is blue, and on our viewing right, you can see that the PLL is broken. But what I want you to look at is how the shape is different. He could have exaggerated it a little bit more for me. When the PLL is interrupted, you have a more lobular shape. The PLL complex is not very elastic. And so if you see significant deformity, if it's not a nice arc, you can be fairly certain that that is a non-contained disc herniation. And what I want you all to realize is those often respond better and have a shorter course of symptoms. So it is something, unlike what we were taught in school, a non-contained disc herniation is actually a good thing. And a lot of what we see on the MRI as this huge disc herniation is actually the granulation tissue of our body trying to phagocytize it. So just as a review, protrusion and extrusion, right there, that extrusion, the PLL is not that elastic to be able to do that. Yes? The inflammatory process bigger when you have a non-contained disc? And the answer is usually it is. Yeah.
Therefore, the increased granulation tissue.
Say that again?
And therefore, that's why there's more granulation tissue.
Yes.
Yeah, okay.
Yes.
I think the question is we're asking whether we should carry on or whether we should seek the help of let's say a neurosurgeon or a spinal surgeon. I think I haven't got up on excuse me. I haven't heard you say anything about the chronicity of the problem, and the chronicity is an issue that I think might determine whether the person with neurological fallout, not necessarily getting worse, but let's say the person is in chronic pain for 3, 4, 5 months and is stopping them from working, stopping them from sleeping. Would you say those are more factors that would determine whether you will be less successful?
That's a really great question, and I would say that chronicity perhaps plays a larger role in the need to have co-management with with others. You know, in the United States, especially because we are such a litigious society, we have to be very careful. It depends on the patient, how well you know them and all. But people who are incapacitated by, even if it's just pain, without deficit, they need help. And that is the point when it would be wise to work with them and get them to someone else who can give them either pain medication or cortisone injections or something to try things. There are always patients who are not going to be able to manage. Yeah. And John's got a study he's going to be sharing with you. All right. I want to keep moving. Here, I just want to show you another high-intensity zone in a patient with a protrusion. That's a lot of inflammation there.
Sorry, Doc. Can you tell me, contact versus non-contained, if there's no trauma, how is that disc material going through the posterior longitudinal ligament? How does it get disrupted?
It's chronic failure. It's desiccation and fissuring. It's just a chronic process.
But the actual PLL?
Yeah.
Why is it going through this?
Because the PLL undergoes the degenerative process also. Yeah, it's just it's a chronic failure of the structure. Take a look at this one. How are we going to describe that? Obviously, as an extrusion. The PLL cannot take on this shape. And you would like to know that the thecal sac is displaced to the right and flattened up against the lamina. But there still is CSF. That's another thing I report on. I will say there is still CSF within the thecal sac. I don't know for sure that that makes a huge difference, but I just like to describe everything that's there so everyone can be informed. So this is a nice example of where you say, oh, wow, there's a huge disc extrusion with inferior migration. But I'm going to pose to you that here is the herniation, and maybe a couple of these dark fragments. All the rest of that is the inflammatory response, the granulation tissue. And we know that because the Japanese actually started looking at the material that they removed. And they found out that there are pieces of annular tissue and nuclear material and so on, but the propensity of these huge herniations is the inflammatory response. This patient only has back pain. This is how different we all are. And I do think that the size of our canal makes a difference as to our symptoms. But you can see, we would describe this, I mean, it almost looks like a tumor in there, it's so big. This enormous disc herniation, a lot of which is granulation tissue, and it has moved here, it's come eccentric to the right. The thecal sac still looks pretty good, and they only have back pain. Here at another one. This was a chiropractor. At age 57, he developed back pain. What was interesting with him is he was comfortable when he was sitting. But when he stood up to walk, he was extremely antalgic, had pretty severe pain, and radicular symptoms on the right. And he was convinced, it went on for about 5 months, he couldn't stand it anymore, wasn't able to treat his patients. And so he decided to go in, get this, he figured he had a herniation, but he got this MRI, and he was ready to have surgery. And he got a Decadon patch, And he was able, within 10 days, he was hugely improved and then could be active, and then he slowly got better. Here, another patient with ginormous extrusion with inferior migration. But take a look at the complexity of the signal. That's probably little pieces of the PLL and annulus. Most of this brighter signal is the granulation tissue. So we don't want to be afraid of size. And this is where I tell you there is nothing on an MRI except when it comes to myomalacia or something like that, you know, and stenosis. But as far as disc herniations, I cannot well predict symptoms or the need for surgery from imaging. You have to base it on your clinical findings.
Sorry, can I just ask one question? Here we go. If on some of those images, if you were to like 3 to 6 months later to retake images, once that whole inflammatory reaction is now decreased, are you saying that it's going to look a bit smaller?
Mm-hmm, and I'm going to show you some. A lot smaller. And John has a fabulous case study to show you.
Sorry, I've got a question.
Oh, yes.
Can you go back to slide?
You bet.
Was that an interdental perineural cyst, Tarlov cyst?
Yes, very good. You're a bright fellow, and I'll be talking about those in differential diagnosis. So that's a perineural cyst, and in this case, it was an incidental finding. They can be symptomatic sometimes, depending on where they develop. Yep, very good. Are you a radiologist in disguise hanging out in the audience? Here is some changes within the cord that you need to report on, and this is a patient that I would immediately want to send out for co-management. But anyway, this patient has got a herniation here. It's obviously an extrusion. It's migrated superiorly and inferiorly, and you can see on the axial images the changes. So I've been showing mainly lumbar, but obviously herniations can happen anywhere. Lumbar first, cervical, and then finally thoracic.
Sorry, can I just ask one more? Can you go back one?
Yes?
The dentocentral synchondrosis there,
Yes, here?
yeah, people may construe that as a fracture. Can you just briefly mention that?
Were that a fracture? So remember that the odontoid forms from C2. It's part of C2. But it has a synchondrosis. That's how it can, get to the full height that it's going to be as an adult. If that doesn't completely form bone all the way through, then you see the remnant of the of that growth center. And that's what we're seeing there. Were that a fracture, I'd need T1 and T2, but you would see inflammation, obviously, because of the hemorrhage and the marrow edema. So that's just the remnant of the synchondrosis. All right, just to review the images, and now I'm going to move into our sequestration or free fragment. So this shows obviously a disc extrusion, but then here is disc material that has migrated posteriorly and it lies against the left lamina. So in this patient, here if you only look at a few of the midline sagittals, you would say that that's probably an extrusion, but then you have to look at the axials as well as the parasagittals, and you can see down below that we're not seeing here, just because of the slice we're at, there is a free fragment sitting alongside the anterior and left side of the thecal sac. And this is one that I was reading, on a busy day, and you're just going through and looking at it, and I'm looking at the shape of the thecal sac, and everything looks good. There's lots of CSF. And then fortunately that guardian angel that sits on your shoulder and speaks to you once in a while made me pause and say, well, what's going on here? What's going on here? And then you look through parasagially through the IVF. And if this is normal IVF, there's our exiting nerve root and vessel and vein here. And that IVF is normal. So we have a far lateral, right lateral disc herniation with a free fragment or sequestration. Does this patient automatically need surgery? That's what we used to think. No. It depends on their symptoms.
Symptoms and signs.
Symptoms and signs, both. Yeah. We got another question?
Good morning, ma'am.
Good morning.
Just wondering about the shape of the posterior longitudinal ligament. The central bit, is that where you're going to get the contained? But what about the lateral aspects? So almost a posterior lateral protrusion. There's almost nothing there.
Yeah, that's a great question. So the PLL, you can remember maybe from yesterday I showed that diagram, and the PLL was running vertically down the back of the vertebral body, but then when it got to the level of the disc, it kind of went out a little bit laterally with fibers. But if you go far, I couldn't tell you exactly, but by the time you get to the level of the IVF, there probably is not much more PLL, and it's just annular fibers. I'm still going to call that non-contained if I see it going through the annular fibers. So we still use that same terminology. But most herniations are at least a bit posterior or slightly eccentric, and so then it does involve the PLL complex. All right, the next thing that I definitely want to cover for you are modic changes, and I want you to understand their role in symptoms in patients. So I may have mentioned that, early on when we were reading MRIs, in some patients we would notice these changes within the vertebral body. And, we were all taught that infections cross a joint, and so it destroys the joint, and then you see bone destruction on either side. And so when we first started noticing that, you would worry, oh, well, does this patient have a discitis that's turning into osteomyelitis? And that's what's going on. So we stuck needles in there, tried to culture out bacteria, and it was aseptic. So Dr. Modic is the one who then went back and started looking at all of these things, and he classified that there are 3 types of modic change, marrow change, that occurs in the end plate. We are familiar with the 3rd type, which is no longer considered painful, from plain film, and we described that as hemispherical sclerosis. And what we would see is these little helmet-shaped areas on either side of a degenerated disc. And when we would see it on both sides like that, and it was shaped like that, we were comfortable to call it hemispherical sclerosis. Now, I would report that as hemispherical sclerosis type 3 modic marrow change. But when it is only in one end plate, and sometimes it's not even helmet-shaped, then, and it's an older patient, you got to worry about metastasis. Is this a focus of blastic metastasis? And that's where MRI will help us with that. But often it will present like this. So that was the end stage. The first type, type 1, is often associated with significant back pain, and it represents marrow edema in the end plates and extending into the vertebral body in an acutely degenerating disc. And that's what we are seeing here. So I hate charts, but this is the best way for me to at least approach the 3 different types. So type 1, which always starts first, is where there are fibrovascular changes within the end plates, often both, sometimes only one, adjacent to a degenerating disc. And because it's acute inflammation, then we're going to, it'll look like water. And what does water look like? On T1, it's decreased signal, it's dark. And on T2, where CSF looks white, it's going to be bright or increased signal. So that is type 1, and that is the painful, it's considered the painful modic changes adjacent to a degenerating disc. With time, it can move into type 2. And type 2 now is a change to fatty marrow. And what does fat look like on T1 and T2? It's bright on both. Sometimes it's isointense, meaning it's neutral. It's not considered bright or decreased in signal. There is thought to be less pain once it moves into that stage. Now, here's what's interesting. We have found in the same patient that it can go from type 1 to type 2 and back to type 1 again. There is this dance that it plays in some patients. But type 3, which we see as hemispherical sclerosis, is considered end stage. And that's where it's dark, because it's cancellous bone along the end plates. So let me show you some of these. So here's a patient with type 1 modic marrow change. So here at L4-5, where CSF is white, water is white, we see bright signal. Whereas in type 1, it is dark. So that is associated with acute degenerative disc disease with spillover into the vertebral body, causing acute marrow edema. In the absence of disc herniation, they can have severe, unrelenting back pain. Until it becomes quiet, it moves into type 2. We learned about this primarily from the days when we used to inject chymopapine. Some of you young people might know about this, but we had a person with a degenerating disc, they had pain, maybe they had a herniation, and what we would do is inject the disc with chymopapine. We thought we would just kind of dissolve the disc. And they developed, many of them, severe type 1 modic marrow change. So while they initially felt better from the lidocaine that was injected, then they developed severe, often debilitating back pain. And when we MRI'd them, it looked like they had an infection. But instead what it was in many of them, sometimes you got infections, but not frequently, we saw that they were undergoing acute degenerative disc disease. The disc was being lysed by the chymopapine, but it set up an inflammatory response in the vertebral body. The literature says that they don't have radicular symptoms. I have seen patients with radicular symptoms from type 1 modic change. And here I want to show you another patient. She's 54. She has severe low back pain and type 1 modic change. So here where the CSF is black, we see black because it's an acute inflammatory response. And here where CSF is white, we see, it looks like an infection. It looks bad, doesn't it? Well, it's an acute inflammation, but it's a degenerative process. It's not infection. Here's another woman with type 1 modic marrow change. Where CSF is white, we see all of this white change. Her disc isn't even that narrow. And here, this dark signal. And up here, we've got bright signal, bright signal. So what is that? That's type 2. Now, it's gone on to fatty marrow change. So her symptoms are here. And I don't know why I have that no herniation. That's a herniation, in my opinion. I just don't have the right axial image. This can occur in the cervical spine. Got a question?
You were speaking yesterday about infection.
Infection?
How would you, I mean, I know you said infection erodes bone.
Yes.
In that previous slide, it did look like the bone was slightly eroded. How would you know if that's an early infection versus modic change?
That's a great question. And the only way I can answer that is you'd have to put it together with that patient's symptoms, look for other areas of perhaps, of course it almost looks like it here, but you would look for areas of abscess tracking up and down. And then the other thing I will say is modic marrow change is more common than osteomyelitis in the spine or discitis. But those are the dilemmas that we do face.
Sorry, Doctor?
Yes.
My opinion on discitis, for instance, is there will be a whole myriad of other symptoms, including fever, raised CRP. I think so, although one would need to investigate something like this clinically.
Yes, and I'd like to say that every patient with spinal infection has leukocytosis, fever, but that's not always the case. And if I have time, I'm going to be showing you a case of infection in the spine. So it is a dilemma. You have to look at all of the different things.
There's a question here with regards to Pott's disease.
TB of the spine? Yes. And what is the question?
She wants to know, is the presentation, early presentation, similar to that as well?
It can be. There's almost always pulmonary changes. Not always, but almost always. It's a little bit more common in the thoracic spine because of the proximity to the lungs. TB doesn't have the same inflammatory response. It's a slow infection, and so but I have seen TB of the spine that looks a lot like that. It's a very valid question. Yeah.
Morning. Back here.
There you are.
It's a few slides back, but it's fine. You're saying that you've seen that there's a change in modic change 1 to 2 and then back to 1?
Yes.
Is that as a result of a recurring acute inflammatory process relapsing, then it goes back to 1?
That would be my guess. I don't know for sure, but yes. It kind of goes into remission, maybe we can say. And then for whatever reason, it begins to really degenerate again.
And then does it eventually get to modic change 3?
Not always. Okay. Not always. I don't see modic 3 changes on MRI
often.
Very often. No. It's more often 1 and 2.
Thanks.
Yeah. Question here? Marie, I remember from yesterday.
Have you noticed any correlation with any other autoimmune conditions with these inflammatory changes?
With the modic changes? Yeah. No. I haven't found that it is more likely, and I have a slide. The people who get modic changes are more likely to be obese, do heavy labor, and smoke. I haven't found it with autoimmune processes. They get their own end plate changes, but they're not considered to be modic. Yeah. Okay. So type 2, I just want to, you've seen a couple, but it's bright on both T1 and T2. And Bill Morgan, who is now the president of Parker University Chiropractic School, he shared these, with everyone. It's open source. And he has nice diagram showing the yellow fatty marrow change. So that is no longer considered to be painful. And here's a patient that has both type 1 and type 2, and now you're able to look at that and say, bright on T1, bright on T2, that's the type 2 modic change, whereas up here at L23, we have bright signal on T2 and iso-intense or slightly dark signal on T1, so that's type 1. So the L23 level is more likely to be symptomatic. And this person's got a bunch of problems, but it was one example of type 3 modic change that I had on MRI. It is not this patient. That's what it would look like on X-ray, but you can see dark signal within the vertebral body on both type 1 and type 2. But they have degenerative retrolisthesis of L4, degenerative anterolisthesis of L3. So they got a bunch of problems. And then because it becomes cancellous bone, you can see why it would be dark and void of water on an MRI. So here's what I was talking about. The Germans put out a good study. Those are the people that are more likely to have modic marrow changes. And I would say that I see modic changes on perhaps 15% of the lumbar MRI studies. Maybe that's hard to say. So anywhere from 15 to maybe 25%. So it is not the majority of people that I see that with. And we've already talked about this, which level, so if they've got type 1 and type 2, what level is more likely to be symptomatically? It's obviously the type 1. And here's a woman who had radiculopathy. Now, she has got type 1 modic marrow change at the L4-5 level. It's hard for me to say whether that is a bulge or a protrusion. I think she's got maybe a hair of anterolisthesis, but really her radicular symptoms are more likely due to the modic change. All right. So I've alluded to this, and John's going to discuss this in some detail, but I will say that we now know, what happened to disc herniations before we did surgery? Patients got better. Some people didn't. Some people had permanent deficit, but most people got better. And the reason why they did get better is because of the phenomenon that's well documented now called disc regression, disc resorption. There's lots of different things. And we know that it occurs with a great many of disc herniations if they do not, in fact, go on to surgery. Is it a normal disc? No. But the lot of that disc material that has herniated is resorbed. So just like a bacteria, disc material, where it shouldn't be, is recognized by the body as a foreign object. And so the phagocytes come in, engulf it, and the phagocytes come in through the vascular supply, and then those big, bulky phagocytes cannot get back into the bloodstream, and so they are carried away by our lymphatic system. So our job as chiropractors, for the ones that can be treated conservatively, is to promote blood flow and lymphatic flow. And remember, lymphatics are not muscular, and we have to rely on the surrounding muscles to carry away those phagocytes. So that's why it's so important to get our patients moving, and John will be going into that. So I've had the opportunity over the years to see the same patient with an acute disc herniation, and then later, some of them had the images done later just because they were amazed at how much better they were, and they paid the money to see it. So here's a patient when it's acute, and they have a disc extrusion, and then 15 months later, that same level. Is it a normal disc? No, but they are no longer symptomatic. So a lot of this was then phagocyte. Some of it is granulation tissue to begin with, and then it is carried away. And here's that same patient. So let's look at it. This is when they were acute. And if you compare those two sides, you can see all of this inflammation or granulation tissue. There's very little CSF in the thecal sac. And now, 15 months later, you can see the CSF is more freely flowing, and you can still see that fissure, or I'd like to call it a tear in this case, through which the herniation occurred. So that whole complex, that PLL complex, heals, it scars over, but it's not normal. But it is no longer symptomatic. So, and here's another patient. And this one is 8 years later. So they had an acute disc herniation. Why am I calling that acute? Even off the images. The HIZ, right? So they've got bright HIZ here. And there it is. And now, 8 years later, other than the fact that it's desiccated, that's a pretty nice looking disc. No surgery. And then I mentioned to you yesterday that what plays a role in degeneration? Genetics, nutrition, trauma, biomechanics. This is a patient who's been on dialysis many, many years for a combination of diabetes, and then you can see they have kidney disease. But as we know, people with diabetes and renal failure do not have good nutrition to their body, their cells. And that's what it can lead to as far as degeneration. In my opinion, over the years, people who smoke, heavy smokers, really degenerate as well. So I want to I only have about 11 minutes left. I want to quickly talk about some other important types of disc pathology, rather than just herniation. So there are other things we see: Schmorl's nodes, limbus bones, Schurman, and I want to be sure and cover this. So you all know what Schmorl's nodes are. Those are intra-body disc herniations. They generally occur during adolescence when the end plates are not yet mature. They're partly bone, partly still cartilage because of the ring apophysis. So they herniate, and they can lead to accelerated degenerative change. How do we know whether it is an acute Schmorl's node versus chronic? We look for that cortication around it. So this is an adult, it's not an adolescent. When we see multiple Schmorl's nodes in the thoracic spine, we want to think of Schurman's. In the lumbar spine, what we used to call Schurman's of the lumbar spine, we now call lumbar juvenile discogenic disease. The other thing I want to discuss is limbus bones. And that's similar to a Schmorl's node, but the disc herniates obliquely, and it separates a corner of the ring apophysis. So this occurs during adolescence when there still is a ring apophysis. And when they occur anteriorly, they might have some fleeting back pain, but usually there's not a lot of disability. And we see them later on, where in the adult, where we see the chronic deformity of the vertebral body. So you see this kind of thing. Let's say a patient has had a recent fall. You should not think that that's an acute fracture. It is well corticated. It's at the anterior superior corner, which is the most common location for these limbus bones. But you know that that's not a normal disc, but that's not an acute fracture. The one that we do need to pay attention to is the posterior limbus fracture. Again, it occurs during adolescence. It is often related to a significant trauma, and I have a case to show you of a football player. The most common sites are here at L4 and 5, but I also see them thoracolumbar. Often we won't see them until later on when they have partially healed, but that's what we're looking for. If you look at this level, that's the normal contour of the posterior aspect of the vertebral body, and you can see the changes. You can see even the end plate irregularity. So during adolescence, they had an oblique disc herniation that fractured off a piece of the posterior aspect of the vertebral body. Up here, T12, this was a gymnast. In another patient, thoracolumbar. And this was an acute one that came across my view box. So this young guy took a helmet to his back and had acute low back pain and left-sided leg pain. So if I draw your attention here to this vertebral body, normal, and then follow along at L4, and then suddenly you see this triangular piece of bone. And I also think I can perhaps see some of it on the AP view. Not great images, is back with film, and he was a really big football player. And so this is important for you as chiropractors to know, because you don't want to adjust that level. It's an acute fracture. There's a lot of hemorrhage. Depending on their signs and symptoms, maybe they need to have an MRI. We want to see how much canal compromise there is, but often these patients can be treated conservatively. They need to be in a brace to limit movement for a period of time. So something to think about in your young athletes with a significant trauma, acute low back pain, and often radicular symptoms. So Schurman's, I'm not going to say much about this. You are all familiar with it. It's thoracic spine. We look for 3 contiguous levels: deformity, Schmorl's nodes, uneven contour. And the thing about Schurman's disease is it's generally self-limiting. So while they might have more degenerative change in the thoracic spine, they don't usually have chronic thoracic symptoms in adulthood. And just to show you some of the radiological findings. But what I definitely want to talk about is this entity, and I think, is Mario here today? Yeah, there you are. When you said you had Schurman's, and was that lumbar? You don't remember. But maybe what you have is this condition. Lumbar juvenile discogenic disease, we used to call it lumbar Schurman's, and we see the same thing. End plate irregularity, Schmorl's nodes, there might be some anterior wedging, but these people, they say it's higher in competitive athletes. I think they just get more x-rays. It's not caused by the trauma. It's now thought to be a collagen, an inborn error of collagen, especially along the end plates, because there's definitely a familial trait. And here, this is a 28-year-old male. And he has got lumbar juvenile discogenic disease. He's got end plate irregularity, there's anterior wedging, there's significant disc narrowing at multiple levels. He's kyphotic. He's trying to open up that canal because of what's going on. The other thing he's got is short pedicles. And I have never seen it in the literature, but my experience with this condition is that these people also have short pedicles. So what does that mean? A smaller canal. And that's another reason why they're more symptomatic. Yeah, so that's that same guy, and there's his AP view. MRI is great for seeing the degenerative change. This was a very young patient. I think he's only 26. Look at his spine.
Doctor, can I ask a quick question from the webcast?
Of course.
2 questions quickly. The person's asked, on some of the MRIs previously seen, there are multiple areas of posterior cord compression as a result of what happens to be ligamentum flavum. How much influence does the bulging of ligamentum flavum have on radicular or discogenic symptomatology?
So if we're talking about lumbar spine, we have a thecal sac. There's no longer cord, and the preponderance of literature says that the compression of the thecal sac is not what's causing the radicular symptoms. It's the inflammatory process.
Okay, and then number 2, study of choice for a patient with a pacemaker. MRI is obviously not an option. Is that correct?
I think for the most part, it is thought to not be a wise choice in a patient with a pacemaker. So then perhaps we have to go to CT. A CT myelogram. Yeah. All right. I'll end it here.
Thank you very much, Dr. Serin. Thank you.
Wonderful. Thank you very much.
Thank you. I'll see you all this afternoon, and we can do some more questions.
Great. Guys, I don't know who wants to go to Sun City. Hands up. All right. Can I ask Dr. Serin if you can just grab something, please?
Every time I look at this bowl, I think it's popcorn. This is the way I used to survive chiropractic college in my residency, popcorn with a bowl like this. Oh, I think there's a couple. Or are they really long? Oh, no, they're just really long.
Obviously, they're very appreciative of you guys in our profession.
So compliments of Nedbank. Going to Sun City is
Dean Wilson. Is he here?
Okay, Dean, come see me afterwards. Give me your email address and details, and we'll be sending you a ticket for 2, so you can take a friend. Okay, well done.
It does back in, right?
Guys, tea time. Half an hour. Please be back promptly. There's no scanning required yet.